I'd like to talk about our research findings and explain some clinical cases. Temporomandibular disorders, that is, jaw functional disorders, which is characterized by symptoms such as difficulty opening the mouth, facial pain, and headaches. To understand at what age it begins and what its cause takes, we performed an observation of jaw joint sound. That is one of jaw disorder symptoms. I'd like to report the result of a 5-year observation of jaw joint clicking sound of Japanese children from 1987 to 1902.
Mr. Torii from Shizuoka City is the host. Collaborating with a friend who is a teacher, since about 3 years ago, we have been investigating the condition of children's jaws and bites. The teacher chose the northern region of Shizuoka City for the...
Okay, sorry. Temporomandibular disorders, that is jaw functional disorders, which is characterized by symptoms such as difficulty opening the mouth, facial pain, and headaches. To understand at what age it begins and what its cause takes, we performed an observation of jaw joint sound. That is one of jaw disorder symptoms. I'd like to report the result of a 5-year observation of the jaw joint clicking sound of Japanese children from 1987 to 1902.
Mr. Torii from Shizuoka City is the host. Collaborating with a friend who is a teacher, since about 3 years ago...
Mr. Torii from Shizuoka City is the host. Collaborating with a friend who is a teacher, since about 3 years ago, we have been investigating the condition of children's jaws and bites. The teacher chose the northern region of Shizuoka City for survey.
That's the reason why ongoing surveys...
Compared to urban areas, there is less population movement due to transfers, etc. That's the reason why ongoing surveys can be conducted.
The survey is conducted twice a year, targeting 123 children from kindergarten.
The survey is conducted twice a year,
in the Ikawa area.
targeting 123 children from kindergartners to middle schoolers in the Ikawa area.
Thank you very much.
There's no 2 and 13.
Please have a
Thank
look
you very
further.
much.
No matter how
Please
much I
have a
say I
look
don't
further.
remember, I want to be remembered, really remembered.
No matter how much I say I don't remember, I want to be remembered, really remembered.
Yes,
St.
that's
Sarah
right.
just isn't showing up much.
You need to buy tougher
Yes,
things,
that's
really.
fine. You need to buy tougher things, really.
It seems like they are buying strength to bite with their teeth.
In the very end, catch. It seems like they are buying strength to bite with their
About
teeth.
this much. Well, this is the average for these
For around
kids.
third graders,
Average for
about this much.
coming out from the
Well,
mouth.
this is the average for these
Like I
kids.
said earlier.
Average, or rather the maximum,
Was it 140
coming out from the mouth of Saigo. Like I said earlier,
kilograms, you know.
was it 140
Around middle
kilos?
schoolers. There are kids now who can manage around 40 kilograms. Generally, biting
Well,
strength.
even around middle schoolers, there are kids now
When
who
they are small. That's why if they haven't bitten during that crucial time, it tends to be urgent. Just because they've grown bigger.
50 kilograms.
Doesn't mean their biting strength increases. So I think it's a very important matter. That's what I think. That girl we talked about earlier, 3 kilograms. That kind of strength is equivalent to not biting at all. So a little bit, you know. If they can't bite that much, that's really troubling. That's what I'm thinking. They can't bite through it, right? 43 millimeters. Yes, biting like 10 at a pub. Keep it up. Even 5 kilograms. Hang in there. Something like that. Hey, that's good. Kids with poor alignment tend to have less biting strength. That also happens. If the alignment is bad, it becomes hard to bite. Try biting. Go ahead and try. Bite hard, that's fine. After all, they really can't bite well, you know. If their alignment is bad, bad alignment makes it hard to bite. I think there are things like only eating soft things. The development of such muscles. Those kinds of things happen.
To examine at what age jaw joint clicking begins, children aged 5 to 10 were divided into 6 groups and observed for 5 years. A total of 79 subjects were examined. Clicking was observed in 30 subjects, of which 26 subjects had temporary clicking, and 3 subjects had persistent clicking. This is temporary clicking. This is persistent clicking. When the permanent teeth erupt, if they do not erupt in a position that allows the chewing muscles to function optimally, the position of the teeth is adjusted by muscle force, that is bite force, causing a clicking sound. Once the tooth is in optimal position, the clicking sound disappears. The female girls click more frequently. This is thought to be because girls have a smaller bite force than boys, which means it takes longer to adjust the position of the teeth. The period during which clicking occurs is longer, and it is more frequently detected during health checkups. Subjects with persistent clicking had significantly lower bite force at around age 6, around the time of the first molar eruption. These subjects with persistent clicking, lower bite force. These subjects without persistent clicking, higher bite force. How do we determine the position where the masticatory muscles can function optimally? The patient wears an anterior flat bite plate and performs tapping and sliding for 5 minutes. A muscular position recording is obtained. This is the habitual bite position. This is muscular position. In those with clicking, the habitual bite position is not coincident with the muscular position. This patient visited us with her chief complaint of jaw joint pain on the right side, accompanied by clicking sound. She was a 17-year-old high school student. She had been aware of jaw joint clicking since the age of 12. After wearing a bite plate, her pain was relieved and bite analysis in muscular position was performed. First tooth contact point is on second molars on both sides. Bite adjustment in the muscular position were performed 4 times, and the clicking and pain totally disappeared after 5 weeks of treatment. What causes the clicking sound? Initial teeth contacts on both second molars interfered with teeth meeting together, and the jaw then moved back, and the jaw discs were forced to anteriorly move. Upon opening, jaw joint head pushed load the discs, and then discs moved back to its original position. During this time, the clicking sound occurred. This 25-year-old woman visited us with the chief complaint of limited jaw opening and pain in the right temple, neck, and shoulder. She reported that she was often aware of the left jaw joint pain and the limited jaw opening. Her bite appears normal. She reported tenderness on the palpation of the jaw of left jaw joint and the various jaw-related muscles. Jaw opening was 28 millimeters. She reported a stuffed ear on the left side and eye symptoms flashing in the bottom of the eyes. Bite discrepancies were recorded on the discs. Red indicates muscular position. Blue indicates habitual position. After bite adjustment, muscle tenderness of the shoulder, neck, and occiput on the right side completely disappeared. Eye symptoms and ear symptoms also disappeared. Regarding eye symptom, it is thought the excitation of the trigeminal motor nucleus causes excitation of the ophthalmic nerve, resulting eye symptoms. It is also thought that the tension in the musculatory muscles causes the tension in the tensotympani muscles, resulting in a feeling of stuffed ear. Headache. A 31-year-old woman visited us with a complaint of sound in her left jaw joint. She had been suffering from chronic headaches for 6 years. She was diagnosed with migraine by a neurosurgeon and treated with naratriptan hydrochloride and lomeridine hydrochloride. However, her headache didn't reduce. She reported a sound in her left jaw joint when she opened her mouth. Tenderness of the lateral and medial pterygoid muscles and the left trapezius muscle and both sides. Initial tooth contact was noticed in the right first premolar. Bite adjustment were made for 5 times. The number of doses naratriptan was significantly reduced after bite adjustment, and the chronic headaches quickly turned into episodic headaches. After the 4 months, the headache is almost gone. This is the first contact point. This is the record of jaw movement from the first tooth contact point to habitual bite position. These movements couldn't be produced by masseter and temporalis, but lateral and medial pterygoid muscles. The shift from the muscular position to the habitual bite position implies the need for extra muscle activity of the lateral and medial pterygoid muscles. These muscles are smaller than the masseter and temporalis. Therefore, these movements repeated in chewing exceed the active capacity of these muscles, causing myofascial pain. The patient is not able to feel pain in the myofascial of the lateral and the medial pterygoid muscles. Therefore, the patient body emits the referred pain in places on both sides of the head as an alert. This is headache. Vertigo. A 75-year-old man visited us with a complaint of loose, full upper denture. He had to visit the emergency room of a medical hospital 2 years ago. He reported feeling a strong impact in his left ear and then developing severe rotational vertigo. No brain abnormalities were detected. He reported that while he was sitting on a stool and looking at a point on the wall in front of him, his visual point repeatedly moved from the right to the left. A half rotational shift from the muscular position to the habitual bite position was detected on the disc of the mandibular position analyzer. The denture was modified by adding self-cure resin to the bite surface of the both molar because there was no occlusal bite contact of the bilateral molars due to early contact at the muscular position. The vertigo disappeared and the tinnitus decreased. Since patients with benign paroxysmal positional vertigo report feeling a strong impact in the ear just before an attack, it is thought that the sudden change from the muscular position to habitual bite position causes the tensor tympani muscle to contract rapidly, tensioning the eardrum, and this impact is transmitted to the inner ear via ossicles, acting on the ear tiny stone, causing nystagmus. Nystagmus is thought to be a defensive reflex to maintain balance during rotational movement. So if you change your posture even slightly when nystagmus is occurring, you will immediately lose your balance and fall over. It is believed that by making the muscular position with the habitual bite position consistent, it is possible to prevent the sudden contraction of the tensor tympani muscle, prevent the occurrence of unnecessary nystagmus, and prevent the onset of the rotational vertigo. Low-frequency hearing loss and ear fullness. A 66-year-old woman visited us with a complaint of a third molar in the lower right side. She had tinnitus in her right ear, difficulty hearing low-frequency sound, and ear fullness. First, she went to a ENT clinic, ear, nose, throat clinic. As a result of various tests, she was diagnosed with sudden hearing loss and low-frequency hearing loss. She was treated with oral steroids such as isosorbide, difenidone, and domperidone, but there was no improvement. After the bite adjustment, the symptoms of jaw joint sound, right tinnitus, right shoulder stiffness, low frequency hearing loss, and ear fullness of the right ear all disappeared. Her mandible deviated 2 millimeters posterior from the muscular position on the both sides. When the temporal muscles contract strongly and the teeth meet together, the tensotympanic muscle contracts synchronously, which restricts the movement of the chain of the tiny ear bone, causing low-frequency hearing loss. Moreover, tensotympanic tension causes the contraction of the semi-ear muscle canal. The anatomical term is semicanalis musculi tensoris tympani that resulted in ear fullness. Initially, contraction of the tensotympanic muscle occurs intermittently only when the teeth meet each other. However, if the contraction is repeated and prolonged, the tympanic tensor muscle becomes fatigued. The muscle tone becomes persistent, result in hearing loss. High-frequency hearing impairment. 59-year-old woman presented with the chief complaint of detachment of the crown of the lower right second molar. She reported that she was pointed out as having a high-frequency hearing impairment in the right ear. At the complete medical checkup, 4,000 hertz, 40 decibel. Bite adjustment was performed twice, but this gap in the right lower premolar and molar regions did not disappear. So the temporary crowns of the right premolars and molars were fabricated to fill the gap. As a result, the opening amount was improved to 47 millimeters. The sound of the left jaw joint disappeared. The bite force on the right side significantly improved from 5.3 kilograms before the bite adjustment to 10 kilograms after bite adjustment. The bite force, this is audiogram. Red line indicates before treatment, 4,000 hertz, 40 decibel. Blue line indicates after treatment, 4,000 hertz, 20 decibel. This is normal value. In this case, the contracting force of the right tensor tympani, which receives the same innervation, is thought to be weakened. Therefore, it is thought that the tension of the right tympanic membrane was weak and high-frequency sound were difficult to transmit. Coxalgia and lumbago. A 44-year-old woman visited us with severe pain in her left jaw joint and clicking sound. She reported that she had never experienced any of these symptoms before. She reported the coxalgia on her left side since 6 months before the first visit. The jaw joint appeared normal bilaterally. The both hip joint also appeared normal. This is a discrepancy between muscular position and habitual bite position. The data showed that when the patient chews, the jaw moves in a twisting manner. Patients with jaw joint disorders may have bite discrepancy between habitual bite position and muscular position, resulting in an imbalance in the posture of the mandible, head, and neck. Thus, the iliopsoas and quadriceps femoris muscles may compensate to maintain body posture, resulting in a poor overall posture in jaw joint disordered patients. When the quadriceps femoris muscle continuously acts on the hip joint, it can cause coxalgia. The hip pain in this patient may be contributed to this mechanism. This patient complained of tearing pain in the left thigh. The data showed that when the patient bites, his jaw moves in a twisting manner. The pain disappeared after the bite adjustment. Median nerve palsy of unknown etiology. A 68-year-old woman presented with a complaint of food getting stuck in her right upper premolars. She reported that 3 months earlier, she had lost the ability to pinch with her right thumb and forefingers, and had been seen by an orthopedic surgeon who was diagnosed with a median nerve palsy, unknown etiology. The bite force was then measured at the first molars using a bite force meter. The mean value was 37 kilograms on the right side, 13.3 kilograms on the left side, respectively. The statistical difference between the mean value was significant. Bite adjustments were performed 5 times until bilateral teeth contact was obtained. This gap. After bite adjustment was completed, the bite force was measured. The mean was 20 kilograms on the right side and 21 kilograms on the left, with no statistical difference. In the case of this patient, right posterior teeth is brought into occlusal contact, unconsciously exerted an extremely strong bite force. Therefore, it is thought that the molars on both sides were in contact with each other in the muscular position, and that the temporomandibular system was functioning normally without any symptoms. However, if such a state in which an abnormally strong bite force must be constantly exerted continues, the motor nucleus of the trigeminal nerve will be abnormally excited. It was considered that the activity of the trigeminal spinal cord nucleus was suppressed, resulting median nerve palsy. Thank you for your attention.